Good. Well, hi, everybody. Great to meet you all, almost all 100 of you. Thanks for having me, Braj and team. So I'm, like Braj said, I'm a stroke neurologist by training. I trained in San Francisco, then moved to Seattle, became stroke director of a health system called Swedish, and then left clinical practice about a year and a half ago from a full-time perspective to run Sentinel full-time. And so I'll dig right in and tell you a little bit about what we've been thinking about, from napkin to bedside. So as a neurologist and as a clinician alongside my team, we saw this big need for continuous real-time care, especially in our demographic of Medicare-esque patients who are 65 and older who didn't have the ability to access care easily. And just like Robert was telling us, just difficult to access care. But even if you've had a stroke, heart attack, or similar acute event, it's still hard to get back and get treated and monitored and managed for the prevention of the second event or the first kind of other event of MI after stroke. And so our approach has been to build on this influx of IoT and monitoring from a Bluetooth and cellular perspective, connect to patients, but then also understand the medication pharmacology and use that data to help really drive proactive decision-making for the patient. I'll tell you a little bit more. COVID has really propelled everything for us too. And just like Robert was mentioning with his company, we're also thinking about labs. And before, as I'll explain in a minute with Sentinel, we really were part of the after visit. Just like I might deploy a cardiac monitor after someone had a stroke, such as an iRhythm Zio patch in the after visit setting, we've had to shift our thinking to how to support care across the whole healthcare ecosystem before patients even were seen. And in the context of COVID, where we might talk about things like blood pressure, we're talking about things like temperature and pulse oximetry. We were able to use our same infrastructure and architecture that the CDC reported on for supporting COVID diagnoses and contact tracing. Where I had started was to provide support for stroke patients and their caregivers, and it turns out that infrastructure is the same that was needed for contact tracing. And so what we set out to build is a full platform for monitoring, and it's turnkey, includes FDA-approved and validated devices, mobile apps, as well as devices with connectivity, 3G, LTE, for patients without smartphones. So in principle, any patient in the US that has Medicare or an equivalent Medicare Advantage or commercial insurance should be able to access our services and be reimbursed for them. We have a live dashboard for providers and a care team, but it's really much more than that too. We support every vital sign, ECG, activity tracking, and glucometry. And soon we'll support continuous glucose as well, as CMS just approved this from a prevention perspective in Medicare. The way we used to work, as I was indicating, was we'd onboard a clinic or health system, help them identify the right patients, screen them, consent them, enroll them remotely. This is all a virtual digital process now in the post-COVID context. We have a team that speaks Spanish and English and can ship and kind of enroll patients remotely and even log into their phone, just like you might have used TeamViewer before. And then we have the monitoring infrastructure from a service layer to identify, triage, and curate the alerts. The clinicians on the ground don't get overwhelmed with data. And at the end of the month, we help support the billing for small, medium, and large health systems that haven't thought about how to implement recurrent billing processes that the EHR, like Epic and Cerner, make it incredibly difficult.
We'll get a hold of her and say, let's say some bad things about Donald Trump. The same thing with that other.
Okay, well, someone's TV came through. Our vision is quite simple in this new world that we live in. Before we think about how to take care of patients after stroke, after heart attack, or kidney disease and injury, but now we're thinking about how to do this before. Just like Robert was indicating, we all need to think about prevention in the cardiac context, or in our case, a cerebrovascular context. And this software, starting with monitoring, plus the new change and shift to video, really enables us to think about how to curate and stitch all these services together so that in principle, by the time you show up to the clinician, everything should have been curated and organized for you. The way I like to think about it is, Braj and I both, and probably other neurologists who are on the call, have seen many people with numb toe, and really what they needed first was probably diabetic A1C testing, maybe a little bit of cardiac monitoring if it was indicated, and probably they didn't need to be seeing a stroke neurologist. And this could be true for a number of conditions, such as reflux after barbecue or spicy food. Maybe you need monitoring, video visit, Tums or Nexium instead of versus nitroglycerin, and then you get curated straight to cardiology as opposed to seeing primary care doc and waiting in an ED in another scenario. I'll tell you a little bit about how we've used this physiology architecture to really drive advanced decision making. So the biggest challenge we've all had, and even a paper came out in JAMA earlier this week, it's very difficult to monitor and manage blood pressure, and clinicians have a significant amount of inertia. Patients aren't necessarily adherent in picking up medications at pharmacies in the retail setting, and that's gotten worse over the past 3 years. Blood pressure control has worsened every year for the past 3, and average control in the US is about 40%. The way we change that is by giving clinicians the data to help decide when to treat. And our data that we presented at American Heart yesterday suggests that we're reducing Framingham risk by about 80%. In the cohort of patients that we're treating, who, as you can see here, have systolics of 220, we're able to bring them down to much closer to normal for patients after MI or stroke. This is all tied together with cloud-based learning and reinforcement learning to then synthesize a specific strategy around understanding who's deviating from pharmacology, when they should be treated, and then how we can treat them with the next med intensification. And in the future, we aim to start delivering meds to the patient's home to start fulfilling based on the plans, the PBMs that they have. I'll give you a quick example. Here's an example of a patient, one of our angel investors, incidentally, from Sand Hill, who has very high heart rates, got diagnosed with AFib earlier this year. This patient's heart rate variability is high. And while he's taking a medication for AFib called amiodarone, which is a cause of stroke and heart attack in some cases, but mainly a driver of stroke, amiodarone is a medication that can prevent that risk. And so this medication, he took a pretty high dose of 160. This is his chart, incidentally, that we're productizing. And his goal was to get off the meds and take smaller doses over time and decrease his load while decreasing his AFib burden. And so he's precisely treated himself. We talk about this precision medicine notion, but this is how he's done it. For us, we've productized this in software from a blood pressure perspective or from a cardiac monitoring perspective, such as this. And so we're able to not only detect these simple changes that portend clinical deterioration, such as in the case of CHF, someone's systolic dropping, their heart rate rising, that in general indicates this patient's going to need potential diuresis, beta blockade, and other advanced measures before hospitalization, before the weight gain. We're able to think through this and use a software to guide us ahead of time. In other scenarios, we're able to tie different types of physiology together. In principle, if someone's on beta blockade, like metoprolol, and their heart rate's rising in the face of metoprolol and their step count is decreasing, it stands to reason that patient's deteriorating. We think about this sometimes with the 6-minute walk test, neurologist uses for Parkinson scales and MS scales. No one's ever tied all this to data together and start thinking through how we can alert ourselves in real time to then make decisions around how to intervene for this patient. And so that's in general what the goal of Sentinel is. And there's a big team behind me. Jorge Sanchez, our medical director, Noah, a technologist who's head of product line at Imprivata, a large healthcare tech company, and then of course, many, many others. Thank you for having me. I'll take any questions.
Hey, yeah, thank you. Great presentation. Yuli, go ahead.
Thank you, Nirav. That was a good presentation. Is your product mainly for people who have been hospitalized and then post-discharge, or can this be for regular outpatient care? Regular.
Yeah, it's a good question. We started with the former, thinking through sort of my hat as a hospitalist who took care of patients in the stroke clinic, but now we're truly in both scenarios, trying to prevent in high-risk patients from a primary care perspective as well as secondary after the event.
I see. So how do you charge? What's your business model? How do you make money?
We make money by helping clinicians in fee-for-service access remote physiologic monitoring, which is a new reimbursement structure starting in 2019 and improved in 2020. And then we use other reimbursement strategies for other parts of the care we deliver. Cardiac monitoring has a whole suite of codes associated with it. And then on the medication side, in the future, we'll start working with PBMs, the pharmacy benefit managers as well.
I see. So do you take a cut of the reimbursement?
That's right. Well, directly or indirectly, yeah, that's the net effect. We take revenue of the potential revenue that clinics make or flat fee services, depending on what's legal and ethical and compliant within the state we're operating. We're in 25 healthcare organizations. We've been monitoring 4,500 patients. The average age of our patients about 71.
Do you have clinicians on your team that will be doing the monitoring, or who will be?
Yeah, exactly. For small, medium clinics and even some hospital systems that are large, they want to use our care team that speaks English, Spanish, and potentially other languages depending on the region For example, we're live in a hospital system in Springfield, Mass, and there's a larger Vietnamese population. So we staff Vietnamese for them. We help these systems now at the hospital side go live, generate revenue so that the CMO can then start using this to bring this into other parts of the care ecosystem. In our case, where we're going to go along the monitoring infrastructure is acute. So real-time blood pressure, real-time ECG to virtualize the ICU or the PACU.
There's a
And
question. Yeah.
what kind of devices do you use to collect the data?
Well, all various vendors. So we're third-party device oriented. We work with the best vendors. We go try and build relationships, test the devices ourselves, make sure that patients can use them, that it has one button, not two, that it's easy to sync to the cloud if it's a Bluetooth device. And so we have partnerships with over 10 vendors now and growing.
And do these patients are usually at home, or are they in assisted living or
Oh, yeah. So
other facilities?
After this question as well, it's a variety of both. It can work at the bedside in SNF and ALF settings. So right now, I'll put an article in the chat. We're specifically monitoring COVID and risk of COVID deterioration in 1,000 patients in nursing homes in Seattle, where patient 0 was for COVID. But then broadly speaking, we can be anywhere, right? The beauty of monitoring is we can monitor anything, anywhere, as long as it makes sense clinically and we can kind of drive better outcomes.
Now, do you have any studies where you've shown positive outcomes from using your technology?
Yeah. So as I mentioned, we've presented data in 3 different places. Last week, we presented American Heart, hypertension around 1,500 patients and improved outcomes from a Framingham score risk perspective on a blood pressure basis. We presented a smaller cohort last year, and we've presented SNF readmission reduction data in 2017 as we were first thinking about this.
Great. Can you put those references in the
Happy
chat,
to.
please?
Yeah, happy to.
Thank you very much. Let's